Now let's address some of the issues related to validity. And we're going to jump right into just looking at some scales first and understanding a little bit more about what validity is about. So let's be very practical. Let's compare a couple scales, right? So this is data from a prognostic study using the lower extremity measure, which is a 30-item self-report that was developed for hip fracture patients. The Harris Hip Score is a competing scale that's widely popular and was developed by experts, primarily orthopedic surgeons and other clinicians. So if we look here at this graph, let's just compare the two scales. Here's a 100% score on each scale. This is 0. Time is on the x-axis, where we have a pre-op score. And you may wonder how you get a pre-op score in a hip fracture patient. Well, essentially, you just ask them to fill out the scale after they're fractured. So the pre-op score is a memory score, so how they remember themselves being, or to the best that we can determine. And then after they're injured, they then complete a self-report scale at each one of these time points. So we can see the Harris Hip Score is here in the solid dots, the darker score here, and then we see the LEM, or the lower extremity measure, here, and the small dots. What do you immediately notice is that there's much greater changes in the LEM, especially in the acute and subacute phases of care when we would be wanting to use the instrument. And so then in the Harris Hip Score, there's very little change, and it's pretty flat really after 3 weeks. And so essentially, if we were trying to document change, and especially small increments of change in people post-hip fracture, we would be much better off to use the lower extremity measure than the Harris Hip Score. And so what we would like to do is both of these scales capture the concept or construct of function, because they're asking about functional abilities and patient self-report, but we also are interested in how their scales perform in terms of helping us pick up change clinically, because that's the point of an outcome measure. And so we want it to clinically, which outcome measures do we choose? And this is, we want the ones that are more responsive or better able to document change. And then we also want ones that have meaning to the patient and the caregiver and to us, right? And so and the payers, right? So we want everybody to think that the scale has relevance, right? And so what we're looking for then is comparisons on these items like responsiveness and validity. So responsiveness has to do with how well it's going to pick up change, and we're going to use something called the minimal clinically important difference to determine like how responsive that it might be. And then the other part is, what does it mean? Like, one scale might appear to be measuring function, but it may measure it different than another. And so we're really comparing the same thing. And so that's the question of validity. So how do we get at those ideas? So the first is just to kind of understand the scale itself and read the items. And so here we have a typical way items are set up on a scale, where they're aligned in a hierarchical difficulty. So if we look at these different items, we can see vigorous activity such as running, lifting heavy objects, participating in strenuous sports. That's the high end of activity on this example, which is the SF36 functional component scale. And then the other low end of the items is walking 1 block. And so we can see that's the range of difficulty that this item has. So people were bedbound, they would have a floor effect on this scale, where not all of them would get a 0. If essentially the difficulties were more like for patellofemoral patients that are all active and in sports, well, they would all be scoring either at the top 2 items on the scale, so that would be a ceiling effect. All right, so this is these are the types of things that make a scale more or less responsive, right? Okay, and so the other part of it is you could have more items that were hierarchy listed, so there'd be greater numbers, or you could also have for each item you could have more categories. So instead of just yes, limited a lot, limited a little, limited not at all, you could have a 5-point scale. And sometimes there's a 0 to 10 scale. So the items that they put on the scales make them either more or less responsive. Okay, the other part is usually in the reference instructions, the scale and self-report scales ask the patient to respond to the questions relative to something. And in this case, it's health-related quality of life is the constructor or purpose of the scale. So the attribute they're trying to pick up is how this function relates to their health. So they're not interested in how the function relates to things like, how they're unrelated to health, so personality or something like that. Okay, so let's look at another scale. So this is a lower extremity measure. So this is the one we were just talking about that was more responsive than the Harris-Hip scale. So we can see here, I didn't put all 30 items down, but we can see the items are relatively simple. They don't ask them about the construct isn't related to health. It's more they're just their difficulty in performing the task, period. And so this is a functional scale that's independent of their health status. And so we can see too that there's 5 items on the on each 5 categories for each item, so that has the potential to be more responsive, and it turned out in the comparison to the Harris-Hip scale it was. So that's a good thing for us. This is a very, very popular scale. It's called the lower extremity functional scale. That's widely used, and we can see it has some of the same attributes of both of the other scales, where there's 20 questions, they're hierarchically ranked, and that there's a Likert scale with 5 different categories for each item, and that the construct or attribute is the difficulty that they're having with their associated with their lower limb problem, or because of their lower limb problem. So again, it doesn't mention pain specifically, so it's independent of pain, but it is about their lower limb problem, however that would be defined. So some things we're just learning about is, without any statistics, just picking up a scale and understanding what exactly is the construct of the scale. Are the questions relating to pain? Are they relating to health? Are they independent of both of those? How is that defined? And what are the items, and how many are there? The more there are, the possibility that it's more sensitive. The consequences that usually they have to be, it takes longer if there's more items. So some of the considerations, normally you're kind of assessing a rehabilitation component or component of health condition, and what you want to know is what are these things called psychometric properties, because they reflect, after you've kind of had this kind of general assessment and read the scale, you can also think about, what are some of the characteristics of how it actually performs in patients. And so to understand how they develop the questions and assure that they have the right content or attributes that capture those abstract concepts like kinesiophobia or whatever, we're going to review some different types of validity that helps develop those abstract concepts. So we'll do that next.